Extrauterine Pregnancy Audio Course. Episode 12. After the ectopic. Resolution is not the end. Resolution of HCG proves that active trophoblast has resolved. It does not prove that care is complete. After ectopic pregnancy, the resident must close 5 loops: treatment surveillance, rupture precautions until resolution, RH policy when relevant, future fertility and recurrence counseling, and psychological recovery. Those 5 loops are the structure of the final visit. Do not let the negative hormone result compress the conversation. The patient needs to know whether the treatment has truly finished, what symptoms still matter, how the next pregnancy should be handled, whether local RH policy applies, and whether her emotional recovery is being taken seriously. Biochemical resolution is one endpoint, not the whole endpoint. Treatment surveillance depends on the treatment used. After methotrexate, ACOG recommends serial HCG monitoring until the value reaches the non-pregnant range of the local assay. The reason is persistence of trophoblastic activity. HCG may rise in the first few days after treatment, and then should decline. Failure to fall by at least 15% from day 4 to day 7 after methotrexate is associated with high risk of treatment failure and requires additional methotrexate or surgery. Resolution is often complete in 2 to 4 weeks, but can take up to 8 weeks. Repeat the methotrexate follow-up rhythm one last time. Day 4 can rise. Day 7 should show the response. More than 15% decline from day 4 to day 7 permits weekly tracking. 2 to 4 weeks is common for resolution, but up to 8 weeks can still occur. The patient who knows this is less likely to panic at the wrong moment and less likely to ignore the right warning sign. The patient needs rupture precautions during that entire interval. ACOG is explicit that patients treated with methotrexate should be counseled about rupture risk and immediate return symptoms. Falling HCG lowers concern but does not abolish risk. Severe pain, syncope, shoulder tip pain, heavy bleeding, collapse, or new bowel or urinary symptoms require urgent assessment. Follow-up is not merely a bureaucratic series of blood tests. It is the safety structure that makes outpatient treatment ethical. After salpingotomy, HCG follow-up is mandatory for a different reason. The tube has been opened and the visible ectopic pregnancy removed, but residual trophoblast can remain. Novak describes persistent ectopic pregnancy after conservative surgery and notes that diagnosis is made when HCG plateaus after the procedure. After salpingectomy, persistent trophoblast is far less common, but future counseling still depends on the opposite tube, pelvic disease, and fertility goals. After expectant management, the patient also needs surveillance until resolution. Expectant management is not completed because the patient feels well on day 1. It is completed when the pregnancy hormone has safely resolved and symptoms have not declared rupture or persistent disease. If HCG plateaus or rises, the pathway must be reconsidered. RH prophylaxis should be taught as a local policy issue with real guideline disagreement. NICE's updated guidance says not to offer anti-D prophylaxis for ectopic pregnancy, miscarriage, threatened miscarriage, or pregnancy of unknown location, up to and including 11 weeks and 6 days, and to offer anti-D from 12 weeks to 12 weeks and 6 days when medical management or a surgical procedure is used. Other guidance and local policies may be broader. The Israeli alloimmunization position paper lists ectopic pregnancy among sensitizing risk situations, and the local Hadassah anti-D protocol gives 300 micrograms after ectopic pregnancy, ideally within 72 hours of the event or intervention. The resident should follow local policy and explain that practice differs because the early exposure risk is low, but the future consequence of alloimmunization can be serious. The anti-D numbers are easy to hear once and lose. NICE draws an early boundary through 11 weeks and 6 days, then treats 12 weeks to 12 weeks and 6 days differently when medical or surgical management is used. The local Hadassah protocol uses a broader ectopic pregnancy approach with 300 micrograms within 72 hours. These differences should make the resident look up and follow the local protocol, not improvise from memory during discharge. Recurrence counseling should be factual, without sounding fatalistic. ACOG gives a recurrence risk of about 10% after one ectopic pregnancy, and more than 25% after 2 or more. Farron reviews a wider literature range after tubal ectopic pregnancy, roughly 5 to 19%, reflecting different populations and underlying tubal disease. The message is not that another ectopic is expected. The message is that the next pregnancy deserves early location confirmation. Anchor the recurrence figures to action. 10% after one ectopic means the next positive pregnancy test should not wait passively for the routine first scan. More than 25% after repeated ectopics means the patient's reproductive history has become a major risk signal. The point is not fear. The point is that recurrence risk becomes an early contact plan. Give the patient a concrete next pregnancy plan. With the next positive home pregnancy test, she should contact the clinic promptly. Depending on symptoms and timing, care may include serial HCG and early transvaginal ultrasound until a normally sighted pregnancy is confirmed. This instruction is more useful than come early. It turns recurrence risk into an action plan. Fertility counseling should match the treatment and anatomy. ACOG states that available evidence, although limited, suggests methotrexate does not adversely affect subsequent fertility or ovarian reserve. Farron and Chong emphasize that future fertility is affected by the underlying cause of the ectopic pregnancy, the patient's age and reproductive history, tubal pathology, the opposite tube, and treatment. A patient with one healthy remaining tube after salpingectomy may have good prospects for spontaneous pregnancy. A patient with bilateral tubal disease, absent contralateral tube, severe adhesions, or infertility history may need early fertility referral. After cesarean scar pregnancy, future pregnancy counseling is more specialized. Recurrence and PAS risk must be discussed. SMFM recommends early ultrasound in a subsequent pregnancy, ideally before 8 weeks, to confirm normal intrauterine location and exclude recurrent scar pregnancy, or PAS. The prior diagnosis should follow the patient into the next pregnancy. It is not just a past first trimester event. Contraception counseling is not a separate administrative ending. Some patients want another pregnancy soon. Others need time, treatment recovery, or definitive contraception. After methotrexate, pregnancy should be avoided until resolution is confirmed and for the locally recommended interval, because methotrexate is an antifolate. After severe hemorrhage, surgery, or scar pregnancy, contraception counseling may be part of preventing another high-risk event before the patient is ready. The psychological chapter deserves the same seriousness as the biochemical chapter. Farron reports substantial morbidity after tubal ectopic pregnancy. In one UK study at 9 months, 21% of patients met criteria for post-traumatic stress. 23% had moderate or severe anxiety, and 11% had moderate or severe depression. Farron also describes under-recognized severe trauma after salpingectomy in an Israeli study, including suicide attempts. These are not rare, sentimental, or secondary outcomes. Those percentages should change tone. About 1 in 5 with post-traumatic stress, nearly 1 in 4 with moderate or severe anxiety, and about 1 in 9 with moderate or severe depression means that psychological follow-up is not an optional kindness reserved for unusually distressed patients. It is part of routine ectopic care. The resident should ask, because many patients will not volunteer the symptoms spontaneously. Nature Review's disease primers also places psychological distress, chronic pain, infertility concerns, and quality of life effects among the ongoing morbidities after ectopic pregnancy. A patient may be distressed by loss of a wanted pregnancy, fear of death, emergency surgery, methotrexate exposure, uncertainty during PUL follow-up, fear of infertility, or guilt over decisions made quickly. A smooth medical course does not exclude psychological injury. Follow-up should therefore ask direct questions. Does she understand what happened? Is she sleeping? Is she having intrusive memories or panic symptoms? Is she afraid of another pregnancy? Does she feel guilty? Is she persistently low in mood? Has she had thoughts of self-harm? Grief is expected. Depression, post-traumatic stress symptoms, and suicidality require recognition and referral. A mental health referral should be framed as part of complete ectopic care, not as dismissal from gynecology. Trauma-informed pelvic care also matters because follow-up can include repeated transvaginal ultrasound and examinations. Explain the purpose before the exam. Ask permission. Preserve draping. Pause when possible if the patient asks to stop. Do not imply that distress is irrational. A patient can be medically stable and emotionally unsafe. A complete discharge or follow-up conversation should leave the patient with exact answers. What treatment did she receive? What result proves resolution? When is the next HCG or scan? What symptoms require emergency care? Does RH prophylaxis apply under local policy? When can she attempt pregnancy if she wants one? What contraception does she want if she does not? What should she do with the next positive pregnancy test? How is she coping? The course began by insisting that location is the diagnosis. It should end by widening that thought. Location explains the acute danger, but good care continues until the patient understands what happened, has a safe follow-up plan, knows how the next pregnancy will be handled, and has been asked about the psychological injury that may remain after the hormone is negative.